Okay. Well, good evening, everyone. Thank you so much for being here, and thank you to everyone who presented or submitted a poster. We will have the results of that competition after our speaker. I hope that you guys are enjoying our meal, and then we will also have a speaker presenting on applying advances in PET imaging to facilitate the early diagnosis of Alzheimer's disease, preparing nuclear medicine and radiology specialists for new diagnostic workflows. And we have Dr. Philip Kuo. He graduated in chemistry from Harvard University and then earned his MD PhD from the University of Virginia. His training included residency in internal medicine at UCLA, a fellowship in nuclear medicine, and residency in radiology at Yale. He has board certifications in nuclear medicine, radiology, internal medicine, and nuclear cardiology. He is a professor of medical imaging, medicine, and biomedical engineering at the University of Arizona, where he currently serves as the chief of nuclear medicine and the program director for the Nuclear Radiology Fellowship. His scientific interests span translational and clinical research in molecular imaging. So please, let's welcome Dr. Kuo.
Thank you very much for that kind introduction. Quick way of, actually, I'm no longer chief of nuclear medicine. I stepped away from that to dedicate to myself to research, and we'll actually be moving to join the fray again and be chief of nuclear medicine at a big center in Southern California shortly. So you caught me while I'm still in Arizona, and I'm very excited to talk to everyone today about these advances in PET brain imaging that really have reached new significance. If you haven't already, I've been told that you need to scan this QR code in order to do this pre-test, because this does have CME credit if you are interested in getting CME credit. So I'll give everyone a couple of seconds to scan the pre-test QR code, and you can fill out the questions while I do some initial housekeeping slides here. It's good timing. So let me, okay. So again, this is for one CME credit. So you got to do the pre and post test to get that credit. And it's supported by an educational grant from Lilly. These are my disclosures. And the planning committee and staff of Peerview Institute for Medical Education don't have any financial relationships to disclose. And we will be discussing in this educational activity about some published and investigational uses of agents that are not indicated by the FDA, okay? And so the planners of this activity do not recommend the use of any agent outside of the labeled indications, and the opinions expressed in this educational activity are those of the faculty, i.e. me this time, and do not necessarily represent the views of all the planners. And please always refer to the official prescribing information for each product for discussion of approved indications, contraindications, and warnings, housekeeping notes. Otherwise, Peerview, as well as I, would like to thank Lilly for providing this educational grant so we can have this activity. And again, you need to do these pre and post-test evaluations to get credit. Okay, and there's the post-test QR code, which we will show again at the end. All right, so let's level set. A lot of things have changed very recently, okay? And the current healthcare and practice gaps in radiology and nuclear medicine kind of reflect that. Radiologists, neuroradiologists, nuclear medicine physicians need to prepare for this rapidly emerging era of increased demand for PET imaging in patients at risk for Alzheimer's disease. And of course, we'll talk about why that is, and I'm sure a lot of you already know a lot about that. And the epidemiology really is pushing this forward. AD prevalence is really going to continue to grow, particularly in the US, but also in many parts of the world as the population ages. And FDA-approved and emerging disease-modifying therapies require biomarker-based confirmation of AD pathology prior to these disease-modifying therapies that specifically target amyloid. And with that approval of a disease-modifying therapy that targets amyloid in October of 2023, Center for Medicare Services lifted the national no coverage decision on reimbursement of amyloid PET scans. Importantly, remember, please, that does not mean you automatically get reimbursement, all right? When they lifted that no coverage decision, that now leaves the decision for coverage up to the local MACs, those Medicare administrative contractors. Hopefully some of you there who've had more experience with potentially getting this reimbursed have already shared your experience with the people next to you at dinner who have had less experience with that. I've already heard through my network a lot of very significant regional differences in how the MACs are handling amyloid PET reimbursement. And there's this new biologically based staging criteria for AD that even requires tau PET. And a lot of people haven't done tau PET imaging, so they don't realize that for multiple years now, we've actually had an FDA-approved tau PET imaging agent. So our goals for today are to improve the understanding of the role and importance of PET imaging to facilitate a timely and accurate diagnosis of AD in this era of disease-modifying therapies, and to equip you with the information and skills needed to integrate amyloid and tau PET into clinical workflows to improve early detection and diagnosis of AD. So let's get serious about improving the early detection and diagnosis of Alzheimer's disease. This is that very scary epidemiologic graph that many of you already seen that shows that with increasing age of the US population, the prevalence of Alzheimer's disease is going to increase to scary, scary numbers. So 60 to 80% of dementia cases are due to AD. About 1 in 9 people age 65 and older has Alzheimer's dementia. And in 2024, that's about 6.9 million people. But by 2060, due to the epidemiology of the of our aging population, it's estimated that almost 14 million, or a doubling of the prevalence of Alzheimer's will occur unless we do something about it. So already think about the impact that Alzheimer's disease has on our healthcare system, whether you count those dollars or in the uncounted costs, and that's going to double unless something is done about that to change the trajectory. So why is it important for patients to receive an early and accurate diagnosis of Alzheimer's disease? Well, even before we had amyloid targeted therapies, it empowered patients and their families with a specific and confident diagnosis. You know, a lot of times, you know, when I talk to my neurology colleagues, it's not just the neurologist that's recommending this to the patients and families, but the patients and families will bring this up if the neurologist doesn't bring it up to them. Why else is this important? Well, this is the game changer that's changed recently. It's required for treatment with the recently approved and emerging disease-modifying therapies that target amyloid. Okay, it's a requisite. And clinical trials are also available for individuals at early stages of disease, including ongoing trials at the prevention stage. Ongoing, not approved, of course. So the traditional way of staging Alzheimer's disease was very clinical, okay? In preclinical AD, you were asymptomatic. You had no symptoms. You may have complaints of what they call subjective cognitive decline, but by objective testing, you didn't meet the criteria. Of course, it kind of depended where you were starting at in your cognitive abilities. Then when you have mild cognitive impairment, it remains mild, so you don't really have significant functional loss. You can still, of course, handle all your own ADLs, but there is objective cognitive impairment at that point. And then when you have frank Alzheimer's disease, mild, moderate, and then finally severe dementia, that's increasing reliance on others in order to handle your ADLs, okay? So in preclinical AD, right now, outside of clinical trials, this does not follow any appropriate use criteria clinically for preclinical AD to get amyloid or tau testing, but in clinical trials it's being done, okay? But for MCI, mild cognitive impairment, which you don't necessarily know is due to Alzheimer's disease, right? You can have MCI due to another type of dementia, or for mild or sometimes called early AD, mild dementia. This is the category, MCI and mild dementia, where the amyloid targeted therapies are approved for patients, okay? And so this is a critical area in the clinical stage of Alzheimer's disease where AD biomarker testing could play a really important role, especially now that we have targeted therapies for this patient population. So something I really like to emphasize for the nuclear medicine physician population in this audience, and also the other folks, we traditionally think of nuclear medicine as functional imaging, right? Like FDG PET, a very functional tool. We have to think of ourselves differently here. This applies not only just to amyloid PET and tau PET, but to other areas of nuclear medicine, where we're really becoming more like pathologists, and not just any type of pathology, but molecular pathology specifically. And so we draw this correlation when we have a negative amyloid PET scan or a positive amyloid PET scan. This is consistent or not consistent with amyloid plaque levels that you would see consistent with Alzheimer's disease on pathology. And indeed, this is how the reader paradigms were developed for these imaging agents, okay? Amazing patients and their families, these patients who are going to, for one reason or another, pass away, they expected within a year, volunteered in that last year of their life to get an amyloid PET scan, and after they passed away, to have their brains examined on post-mortem histopathology, and had scoring of the amount of amyloid plaque in their brain, and then correlated the Reed methodology to get those levels of amyloid plaque that we typically see in Alzheimer's disease to be rated as a positive amyloid PET scan. So here we're like molecular pathologists, okay? Not so much functional imaging like we're traditionally used to. Here, if you were to take 100, I explained to patients, if you were to take 100 biopsies of your brain, would we find amyloid in there at levels consistent or not consistent with Alzheimer's disease, okay? The pathology of Alzheimer's disease, not the disease. And now we can also do this with tau, as you see on the right-hand side of the screen. This is a neurofibrillary tangle in the right hash circle there. Tau is actually intracellular, okay, and then the cell dies, and then it can spill out and be extracellular after the cell dies. Amyloid is extracellular, okay? And in the big red circle is actually what we see as a classic amyloid neuritic plaque, okay? So a crucial study, we're not used to in imaging having trials of this size, but the IDEAS trial, the Imaging Dementia Evidence for Amyloid Scanning, in which the co-chairs, the lead PI was Dr. Gil Rabinovici out of UCSF, one of the absolute leaders in our field, worked so hard for our field. This was a fascinating and important study. Single arm, multi-site, longitudinal study evaluating the clinical utility of amyloid PET in Medicare beneficiaries with MCI or dementia meeting amyloid PET appropriate use criteria. Over 18,000 patients were enrolled, okay, and then followed up for a year. One of the most powerful things about this study was it was recruited from about 600 memory clinics. So not just academic facilities, private community, everything, wide spectrum, and over 350 imaging centers again. So real world data here, all right? And that real world data showed that amyloid PET led to changes in patient management in MCI at about a 60% rate, and about a similar rate in patients with dementia, 64%. And this well surpassed the primary objective of greater than a 30% change in patient management. Amyloid PET also led to changes in diagnosis, 25% of time from AD to non-AD. So I'm going to translate that, it led to changes in diagnosis more often when it was a negative scan, right? Because most of the time you thought it was AD. Then it was a negative scan. You're like, oh, wow, okay, let me rethink this. Maybe it's not AD. But it also happened the other way around. 10.5% of the time it changed the diagnosis from non-AD being the leading diagnosis to AD being the leading diagnosis. This was hopefully supposed to get us Medicare reimbursement, but the second objective, which was to significantly decrease rehospitalizations or ER visits, was not met. So we actually did not get coverage. But as we already talked about, primarily due to the approval of amyloid-targeted antibody therapies that require proof of amyloid positivity. In October of 2023, CMS retired that non-coverage decision for amyloid PET and left it up to the local regional MACs now. So let's talk about these game changers. The anti-amyloid monoclonal antibodies for Alzheimer's disease. Okay, so the first breakthrough was in June of 2021. It was kind of a partial breakthrough, and aducanumab received FDA accelerated approval for the treatment of early AD. That was based on the fact that it removed amyloid from the brain, and that was measured by amyloid PET imaging. Okay, but it did not have statistically significant clinical benefit and hence never achieved full traditional approval. And I'll jump ahead a little bit. 3 years later, basically, the manufacturer announced discontinuation of it. One of the major reasons that it announced discontinuation was lecanemab received accelerated approval and then also full traditional FDA approval. It showed biomarker clearance by amyloid PETs. The amyloid was removed from the brain, and it showed statistically significant clinical benefit by slowing the cognitive decline compared to placebo. So that resulted in full approval. And since lecanemab had full approval and aducanumab never received full approval, it's understandable why aducanumab was discontinued. And earlier this year, the FDA said that they were going to hold an advisory committee to discuss donanemab, which also had a phase 3 trial that achieved its predefined endpoints. And in June of this year, that advisory committee meeting will be held. So let's look at these 3 anti-amyloid antibodies that have had positive phase 3 trials, at least for biomarker improvement, as demonstrated by amyloid PET, amyloid clearance on amyloid PET. So Clarity AD in the top left, lecanemab, that is the one that has gotten both accelerated and full approval, okay? And on the y-axis here is something called the Centiloid scale. The Centiloid scale is a scale that was developed to allow us to normalize across all 3, and actually 4 if you count Pittsburgh compound B, of the amyloid tracers. So the amyloid tracers are a little bit different. So we needed a common scale in order to normalize across them, particularly for trials like these that use different tracers. They allowed people to use florbeta-beer, florbeta-ben, or flubenamol. And so Centiloid scale allows you to normalize across all 3. So that's what's on the y-axis here. And on x-axis is times. You can tell, not surprisingly with placebo, there's no change in amyloid burden in your brain. But when you get the lecanemab, you have this decrease in amyloid burden in your brain as measured by amyloid PET. And indeed, the majority of patients actually became amyloid negative by quantification by the end of the lecanemab trial. A similar decrease was seen in the amyloid burden in the brain on serum amyloid PET imaging on donanemab, and aducanumab, the one that got accelerated approval but not full approval, as you can see, had actually a dose correlation. At higher doses removed more amyloid from the brain than the low doses. And to get that full approval, look, we like to see the amyloid decrease in the brain because we know the antibody is crossing the blood-brain barrier, getting into the brain parenchyma, removing that amyloid successfully. But what does that all mean if patients don't clinically benefit, right? And in lecanemab that got the full approval, you can see here, the top line is lecanemab and the bottom line is placebo. There was a significant difference between placebo, but the lecanemab did not completely stop the cognitive decline. It slowed it. So you can see there's a decrease in the cognitive scoring by what's called the CDR sum of boxes score. So they both continue to decline, but the rate of decline was slower in the lecanemab arm than the placebo arm by a significant amount. All right, Donanemab has had a successful phase 3 trial, met its endpoints, is not approved, okay? And some people refer to this as a next generation trial. We've learned a lot from this trial because it not only incorporated amyloid PET like many previous clinical trials, but also incorporated tau PET, okay? And indeed, in the phase 2 trial, it actually specifically selected out patients who had a intermediate load of tau based on this fluoroscopy PET imaging. In the phase 3 trial, they actually included patients with all levels of tau, but predefined that they were going to do a subgroup analysis of just the low, medium tau group, and then a combined one, which also include the high tau group. Why would you want to include tau PET? Well, one of the things is that you become amyloid positive much, much in advance of before you develop symptoms. So, and tau tracks with symptoms much better. So if you were tau negative and amyloid negative, we're going to show this more shortly, you actually are not sure when you're going to develop symptoms, okay? So you haven't necessarily selected out a high risk group yet, okay? But if you have extremely high levels of tau, you might think, okay, this patient is too far advanced, we might be able to help them, because we'd seen in earlier phase 3 trials that if you let in patients with too advanced Alzheimer's disease, you don't help them if you only target the amyloid, okay? So in this donanemab next generation AD clinical trial, which is called Trailblazer 2, we again had that clearance like we did in the Clarity trial by serial amyloid PET imaging that the amyloid was cleared successfully from the brain, and actually very little difference between the low medium tau group and the combined group. Interestingly, the plasma levels of tau also decreased when you received the anti-amyloid antibody, which shows that there's that connection between amyloid and tau. And again, what's all this biomarker improvement mean if you don't slow cognitive decline? And as you can see here on the far right graph, there was a significant slowing of cognitive decline in the donanemab group compared to the placebo group. Again, though, you don't completely stop it. You just slow the cognitive decline, but donanemab slowed it by a significant amount. And 36% slowing of cognitive decline in the low to medium tau group at 76 weeks, or basically almost a year and a half. And when you look back here at this leftmost chart, 81% of all patients who received donanemab became amyloid negative by quantification terms at the end of the trial at 76 weeks. Okay? Now let's take a real clinical case. Part 1. A 63-year-old man who had 1 to 2 years of cognitive complaints, progressive forgetfulness, difficulty with word finding, very common complaints. Kind of this classic, more amnestic kind of AD, maybe early amnestic AD presentation. His medical history actually got a little more complicated, though. He's a former pilot who retired after a crash/ejection about 30 years ago. He's also had treatment for anxiety and depression. Family history, father experienced memory loss late in life, but as you can imagine, a lot of them, they don't really know what it was from. A lot of diagnoses may be presumptive in this age group's parents or grandparents, right? His objective cognitive testing score was 26 out of 30 and 24 out of 26. So just mild objective early cognitive decline. And this is his MRI, right? Non-contrast brain MRI shows this right encephalomalacia here, right? Consistent with this history of prior trauma, the plane accident, okay? There's moderate glial atrophy, as you can see. The ventricles are on the moderately dilated side. And we have some deep insulsi here, right? Particularly in the towards the vertex in the parietal region, as you can see here, but also in the frontal region here, okay? And as you can see, there's no evidence of microhemorrhages, right? That's very important because vascular dementia is a very common cause of dementia and could also contribute in a mixed dementia with AD. The two most common causes, AD and vascular, so they can coexist, but no evidence of microhemorrhages in this patient, okay? Or any significant strokes, as you can see, just that encephalomalacia and the atrophy. So we have a polling question here. Please open up the QR code for this one. and I'll give you a few seconds to answer that while I read out the question. This man with mild cognitive impairment presents for diagnosis. His non-conscious brain MRIs we showed had that small focus of right frontal encephalomalacia consistent with his history of prior trauma. There was moderate global atrophy, but no microhemorrhages. What is his most likely diagnosis at this time? Okay. Not going to read all the answers, but hopefully you'll agree with us that at this time the diagnosis is unclear and we could really benefit from more information. So how can we improve this early recognition of AD pathology with amyloid PET? We have 3 FDA-approved amyloid PET tracers, florbetapir, florbetaben, and flutometamol. Each one of them has a different read methodology, okay? So find out which one you're using, and you need to go and complete the in-person or online training. They all have online training available as well. Okay, and those are the QR codes for the online training for each one of those. Again, each one of them used a comparison with the post-mortem histopathology levels of amyloid to optimize their read protocols. Okay, so they're different. So while they share the same basic principles, to really be the best reader you can, you need to do that specific reader training. Okay? You should do a binary read. Your report should either say positive or negative. You can also, I actually like to throw in normal or abnormal because positive or negative sometimes confuses patients. Positive sounds like it might be good, right? So sometimes I actually use positive / abnormal or negative / normal, but you don't have to do that. And on postmortem histopathology correlation, a negative scan means no to sparse beta amyloid neuritic plaques, and a positive or abnormal scan correlated to moderate to frequent beta amyloid neuritic plaques. All right. For Alzheimer's disease, for which this was deemed negative or positive, you really need moderate to frequent amyloid neuritic plaque levels. Just some none to sparse plaque isn't really consistent with the levels of amyloid you see with Alzheimer's disease. All right, I really like this slide. This shows you on your left-hand column an example of a very clear negative. In the middle will be a sort of in-between, still positive, but not a blatantly positive case. And in the right-hand column will be a classic positive case. Most cases that are positive will be the very obvious positive case, but a significant number will fall into this more difficult category in the middle, where not every region is going to be positive. Okay. So when you start with your amyloid PET interpretation, you start at the base of the brain at the cerebellum. Not until the most extremely advanced cases of Alzheimer's disease. I mean, these are, probably 1 in 1,000 have I seen where you'll actually get amyloid in your brain. So you can safe to assume that your cerebellum is negative for any significant amyloid plaque. So this will be your negative sort of reference region, okay? Depending on the patient, you may get different levels of clearance of the tracer and hence the radioactivity from the cerebellar gray matter. So this level of white matter to gray matter contrast in your cerebellum will be your completely negative control region, okay? So as you can see, high uptake in the cerebellar white matter, and in all cases, whether it's positive or negative, and mild to no, this is just sort of mild degrees of activity in your cerebellar gray matter, which you should tolerate in the rest of the cerebral cortex as no plaque. Okay? So right away, you can tell from the cerebellum, there is normal uptake of radio tracer in white matter. Okay? The tracer normally goes to white matter. That is just normal uptake that you should perceive as benign. And a white matter pattern is actually nice because you actually have uptake and you see a white matter pattern when it's negative. All right, let's look at column 1 first. I love this comparison with this MRI and this fused image. You can see that the uptake in this negative scan registers perfectly to this white matter in the temporal occipital region. Actually, I call this a temporal occipital ridge of white matter, okay? And out here towards the periphery, it's negative, okay? Remember back, it's similar amounts of very mild activity to the cerebellar gray matter. And look in the middle here, in the midline, in the occipital, okay? Look how it's nearly completely devoid of activity. That's because in your occipital region, the gray matter rounds the corner, okay? And in the lining your interhemispheric fissure in all parts of your brain, but including your occipital region, this is gray matter. And so your gray matter shouldn't have any uptake in a negative scan, and so you get this big clear space here. Now, in the next level where this is, I would call this still negative, but as you can see here, that you're starting to get some yellows, a little bit of activity out from the temporal ridge of white matter here, but that's still negative. Okay, you can still clearly, I can take my laser pointer and trace out that white matter. And out here where it's negative, you can still see just mild bits of activity, and in color-wise, it's not yellows. Okay? Contrast that with this positive scan in column 3. I cannot take my laser pointer and trace out that white matter ridge next to your ventricle. The activity next to this periventricular white matter is the same as all the way out here to the periphery where your gray matter is here, right? So now you've lost that gray white matter contrast. You can no longer see that white matter ridge in this fused image, right? These yellows go all the way out to the edge here, okay, where that gray matter is, okay? And as you can see here in this occipital ridge immediately, instead of having this clear gap devoid of activity, it's starting to fill in here, okay? Going a little bit higher up, okay? This is a nice slice to look at your frontal region, all right? Again, look at this big clear space. I call this the diamond clear space in your frontal region in the midline. Look at the MRI, lining your interhemispheric fissure in your frontal region is just gray matter. So when it's a negative scan, you'll get this big gap here. And notice here on this more equivocal scan, it's starting to fill in here, right? Compare these two frontal regions in the midline, right? You can see how that's in the midline here, it's losing that contrast. And also, look here, you can still make out what we call a trident pattern here, and I can still trace out the weight matter here. It's not as positive out to the edge. As you can see here, you lose that trident pattern and you get this smooth edge out to the edge here. Okay, so the frontal region here is positive, but you go to example 3 and this is really positive. Okay, again, smooth edge all the way out here, the gray matter out here at the periphery of the frontal region is positive, but look at the midline region here, almost completely filled in here. Okay, and this really positive scan. This example is also nice for the precuneus and posterior cingulate region back here. See how it's nice and negative here? This is your precuneus and posterior cingulate on the MRI. Filling in here part of the way on this middle example and completely filled in here in your extreme example of positive. Okay? And if you look out at the edge here on the parietal region, it's smooth out here, partially filled in here in example 2. And as you can see here, not filled in at all here out the edge. The gray matter is really completely negative back here in the completely negative example. Coronal planes can be very helpful, not only in the frontal, but also in the region of the precuneus and posterior cingulate as we have here, okay? So negative here, nice and clear, filling in here, and just completely filled in here, okay? Sagittal plane, again, very nice for demonstrating your posterior cingulate precuneus, where if you chop your brain down, right straight down the middle along the interhemispheric fissure, and you're looking at the medial aspect of your brain, it's very easy to see the occipital lobe. Okay, here's your parietal occipital fissure. This is your parietal lobe here. And the posterior aspect of your medial parietal lobe is your precuneus. Okay, this band of white matter here, this band of activity is your corpus callosum. Just above that is your cingulate gyrus. So this is your posterior cingulate gyrus, and just above that is your precuneus, okay? As you can see here, negative in your negative scan, way less activity than your white matter corpus callosum, your splenium here. See how positive it is here, how different it is from example 1 and example 2. and even more positive in example 3. In this case, even your frontal region's quite positive on the sagittal view. All right, so amyloid PET serves as a biomarker for pathological amyloid deposition. But I like to say that amyloid is necessary, okay, but not sufficient for Alzheimer's disease. Okay, you need the amyloid pathology for it to be Alzheimer's disease, but by itself, it's not sufficient to call it Alzheimer's disease. And indeed, amyloid pathology in some trials have been shown to precede clinical findings of dementia by 15, 25 years. Okay, so having the pathology of amyloid does not mean you have Alzheimer's dementia. You need those clinical findings, okay, to call it dementia. Otherwise, you're just positive for amyloid pathology. So, excuse me. A negative amyloid PET scan makes Alzheimer's disease unlikely as the cause of a patient's cognitive impairment. Amyloid is necessary but not sufficient. Okay? But of course, remember, an amyloid PET scan, just like all of our imaging, is not 100% sensitive, not 100% specific, and you can have interpretation errors. Not these intermediate sort of borderline scans, not everyone's going to agree, and they exist. All right. Just so you know some technique, again, know which tracer you're using because the techniques are different for each one of them. Doses are different, uptake times are different, scan duration is different, and the read methodologies are different. Actually, florbetaben, I'm pretty sure that should be a 1. You only need 1 region affected for florbetaben. Okay, and the sensitivity specificities are actually quite similar with all 3 of them. This is now, so you can see it from cerebellum all the way up to the vertex of brain, a very classic amyloid PET scan. The majority of scans, you will have more than 1 region positive. We're going to start at the cerebellum. Okay, this one may not have quite as good cellular gray matter clearance as that other example we showed you. You come up, the occipital region here is very positive, right? Look, that activity in the gray matter in the midline of your occipital lobes, almost touching there. When that activity almost touches, we give that the name of the sign, the kissing hemispheres. There's I wrote a radiographics article there if you want to read about it. I cannot take my laser pointer and trace out that paraventricular white matter, right? It looks homogeneous. Same amount of activity next to the ventricle as it is all the way out to the edge in the temporal and occipital regions. That frontal, look, that diamond clear space is gone, right? And the activity goes all the way out to the edge. It's nice and smooth there. It doesn't have that spiky white matter pattern. And precuneus, posterior cingulate, filled in there. That diamond space is gone. And that activity in the parietal region goes all the way out to the edge. I can't trace out that centrum semio-valley, that white matter, right? Okay, classic positive amyloid PET scan. Okay, beyond this visual interpretation, okay, the quantification programs that you'll have perhaps in your PET software programs, they're not approved for quantification by the FDA, but they are there, so we get a lot of questions about them, okay? So you can do it in various ways, all right? There's regional segmentation. You can do this by the patient's MRI, which you can imagine is the best way. You have the patient's MRI. So you have that individual's anatomy, and then you can segment the PET by that MRI. But you can do it by more atlas methods. So, you know, what is the typical PET atlas you can set up for that individual if you don't have their MRI. You can sample the gray matter only, the gray and white matter. You can do partial volume corrections. So all these different methods. And if you're using a ratio of the SUVs, you have to have a normalization region. That's typically the cerebellum, but sometimes you use the pons. Cerebellum, sometimes you use only the gray matter, sometimes the gray and white matter combined. So all these different methods will have different results if you obviously, since you're using different regions. So these regional SUVRs can vary by as much as 30% depending on the method used. So don't try to compare your results with another labs if they do not use the same quantification software / methodology. But again, as I mentioned, this centiloid scale, which you should learn about because it's how they publish our results in our papers now, it's to normalize to across tracers and institutional data. And the highest, best form of centiloid actually calibrates to Pittsburgh compound B with identical methods. Okay, that's the highest skill of the best way of doing centiloids. There's other methodologies that you might be forced to use for multi-institutional trials because not everyone has access to Pittsburgh Compound B. Okay. And so Centiloids, after you've normalized it and you're on the centiloid scale, what does it mean? Okay. So a lot of times you use a threshold scale of right around 25 centiloids to call something as positive or negative. Okay. So a negative patient kind of within 2 standard deviations might get up to around 25 centiloids. And beyond that, we typically think of, okay, that's usually above what a patient with a negative amyloid PET scan should be, right? So an optimal cutoff for progression who's going to continue to accumulate amyloid, in other words, another way of saying that was a true positive, is around 26 centiloids. For agreement with whether it visually read as positive or negative, it's a little bit higher, around 40. Okay, because that is levels of amyloid that are supposed to be moderate to frequent levels of amyloid that are already consistent with Alzheimer's disease pathology. So you can see on this graph on the right-hand side here, around 40 is where things are starting to will get called visually positive in the red, and below 40 is visually called blue or negative. Okay. And this is for one particular tracer's SUVR, but it will be different, this x-axis, depending on which tracer and even which institutional protocol, which kind of scanner, what type of reconstruction algorithm, anything. Okay. But a pretty nice correlation between SUVR and centiloid scale for any particular institution. And then you can calibrate across. All right. Going back to that IDEAS study with 18,000 scans, how did local reads of radiologists in the real world and nuclear medicine physicians compared to quantification? Very nice work done to have, hey, if we use quantification as sort of an independent measure of how these RIDs were done out in the community by people without mounds of experience, like someone like me who's read over 10,000 scans in clinical trials. The people who are maybe just starting, how did they do using quantification as an objective measure of how they did? And we used a centiloid threshold 24.4, and as positive, above that is positive. And there was actually 88% agreement with the site radiology and nuclear medicine reads. So quite good, actually, I think. All right. So there's obviously some amyloid imaging limitations. A lot of these are common to nuclear medicine and radiology in general. Okay. Some scans will have low signal to noise. You can have this off-target binding, as we said, with this white matter. If a patient moves, you can get some blurring. You can have attenuation correction artifacts. I've seen patients move, right? And then actually attenuation correction actually does worse because you add counts and take away counts where you should or should not. Cortical atrophy is probably the most common reason for a difficult scan. If there's not much gray matter there because there's atrophy, it's going to make a tough call to know whether there was uptake in the gray matter. My advice in those situations is to really try not to interpret areas of atrophy. So look, even those low dose CTs are actually pretty good for assessing areas of atrophy. Avoid those areas and weight far more in your decision making those areas with less atrophy. And there's always going to be some inter-reader variability. There was not perfect agreement across readers in the inter-reader agreement studies that led to FDA approval. So let's have a moment for you to put your QR code in here. I'll just read this question really quickly. All right. At your clinic, all the amyloid PET scans are visually interpreted by a trained clinician, and then you use the quantification software to give you a centiloid score output. The last 2 amyloid PET scans were scored. The first one was scored positive on visual read, and it had a centiloid score of 60. Okay. The second one had a negative visual interpretation and a centiloid score of 50. Okay. How would you classify the concordance between the visual read and the centiloid? And hopefully everyone got the right answer, which was scan 1 was concordant, read visually positive centiloid score of 60, and scan 2 was discordant, okay, was negative on visual interpretation and centiloid score of 50, okay. Generally, for visual, it was about 40, okay. Centiloid score were above 40. It correlated well with visual interpretation of positive. Right, this says discordance. It doesn't really tell you which one is right, okay? So if you look at that visual, at that scan again, and you look at like, okay, that's negative visually, there's a chance that this quantification was performed incorrectly. And in my experience, the most common reason for that is either atrophy, right? Or the reference region, whether it's the pons or the cerebellum, was a little bit off, okay? For example, if you had some cerebellar atrophy, that could really skew your reference region, and you're normalizing to your reference region. That could be a real source of error. Okay, so moving from the diagnosis to prognosis with tau PET, all right? Tau PET, we only have one approved tracer, fluortaucipir, okay? Here are the the uptake times dose duration, so different, all right? So make sure you use that. And it has a different image display for reading these than anything else we use, okay? So there is very, very specific reader training for this. And a lot of that reader training is make sure you set up just the image display properly, okay? And so you actually have to set an upper contrast value, okay, that's set at the mean cellular counts at 1.65. And you set this to a color scale that has a sharp transition at that level, okay? If you need to start reading fluortaucipir PET, all this is delineated in the reader training for fluortaucipir. Do not read it without that specific reader training first. It's completely different than anything else we do. Okay, these results, it's important to know what this means. Again, how does it correlate to the pathology? And a positive fluortaucipir scan really correlates to amounts of neurofibrillary tangles that you really seen with Alzheimer's disease. So these are Brock scale tau pathology score, and this amyloid PET tracer is not sensitive to early levels of tau deposition, Brock stages 1 and 2. It's really sensitive for Brock stage 3 and above, the ones you really see with frank Alzheimer's dementia. All right. Some specific read criteria: a positive scan will show increased neocortex activity in the posterolateral temporal lobe, occipital or parietal precuneus regions in either hemisphere, okay? And again, a positive scan supports the presence of widely distributed tau neuropathology. This is not really sensitive enough to get early tau neuropathology. And a negative scan shows no increased neocortical activity or increased neuroactivity in the mesial and anterior temporal lobes, or just isolated to the frontal region, okay? So in the temporal region, for a positive scan, you need to see it in that posterolateral temporal. That mesial and anterolateral temporal uptake does not count towards positive, okay? You also get off-target tracer binding in choroid plexus, striatum, brainstem nuclei, specifically substantia nigra, okay? So that's actually present on almost every scan to some degree, okay? The reference region, again, is this inferior cerebellar cortex. We specifically state inferior because we don't want a spillover from uptake in the inferior temporal occipital lobes to get into your cerebellar reference region. It will throw off everything, okay? So for determining tau positivity in research, really, we don't have a consensus yet, okay? And which regions to use, like entorhinal cortex, which is the first area involved, and amygdala and pericampal, hippocampal, we don't really have a consensus. And honestly, it's probably going to depend on which tracer you're using, because there's even next generation tau agents that have not been approved. So our next audience polling question, get out your QR code. You are reading a F18 fluortaucipir PET scan to determine whether it is positive for Alzheimer's disease. Which of the following patterns would be most likely to identify as positive? Okay, a lot of words here. Hopefully everyone got the right answer. It's increased binding in the parietal neocortex and the occipital neocortex. Okay, remember, mesial temporal and anterolateral temporal lobe activity does not count. Okay, it's posterolateral temporal lobe that counts towards positivity. All right, choroid plexus and striatum, you'll see very commonly is just off-target binding, totally non-specific. Okay, increased binding the cerebellum, you don't look at. That's really your reference normalization region. Isolated frontal neocortex has been seen and is not consistent with AD. You see that with other things, okay? So implications of tau PET results. Okay, a tau PET is a biomarker for pathologic tau deposition. Again, we're like molecular pathologists. Tau pathology has a stronger temporal correlation with neural injury and cognitive impairment than amyloid pathology, okay? Amyloid, you can be positive for 20 years and not develop any symptoms. That is not true with tau. Tau has a much tighter temporal correlation, okay? So fluoxetine and many symptoms, sorry. Fluoxetine and many other tau ligands bind to the form of tau that occurs in AD. There's lots of different isoforms of tau, but fluoxetine is more specific for AD. So it is approved for AD tau pathology assessment, not other tauopathies, okay? And again, having that AD pathophysiology does not mean dementia. That requires clinical correlation. Okay, a positive tau PET scan supports the diagnosis of AD in the setting of cognitive impairment, and a negative tau PET scan does not exclude the presence of tau pathology sufficient for the diagnosis of AD. It's really the more advanced tau deposition that you get positive tau. So you can be amyloid positive and not develop any symptoms for quite some time from Alzheimer's disease, but tau really is a very tight time when it's, by the time you're tau PET positive, most patients are actually already having dementia symptoms attributable to AD. So much tighter time correlation. This is an example of a temporal correlation. Negative fluoxetine PET scan. Okay, normal off target you can see in the orbital regions. You can see some of the bone marrow, the skull base. Basal ganglia, substantia nigra, all normal off target stuff. Doesn't contribute to any positivity whatsoever. Okay, so nothing in the neocortex here. And this example of a positive one, right? See, this posterolateral temporal is positive, okay? All right. And you will put it in a color scale. This is one type of color scale. Another is a red-green one. And the posterolateral temporal cortex here is positive. Actually, the occipital is as well. This is starting in the occipital region. Also positive in the parietal regions here, okay? But negative, at least in the included frontal regions. So this would be positive fluoxetine PET study. All right, let's again show what is the significance of tau, right? So progression to mild cognitive impairment, when you're amyloid negative and tau negative, a very small chance that you're going to progress to MCI is probably something non-AD, right? And when you're amyloid positive and tau negative, right? So while you're tau negative, your progression to MCI is still very unlikely, similar to being amyloid negative and tau negative. Again, how just being amyloid positive doesn't have that much predictive power. But look at that additive predictive power when you become tau positive, okay? Much more likely to progress if you're tau positive, okay? And also, almost when you're looking at AD, everyone's already amyloid positive. Could become amyloid positive first, then you become tau positive, right? And amyloid positive, you can be amyloid positive for many, many years before you develop symptoms, right? But tau positive, you will decline very much faster with much greater likelihood. Okay. There's some Society of Nuclear Medicine and molecular imaging resources. All right. There's an amyloid portal page, so you can, even after you've done the reader-specific training from the manufacturers, you can then go and practice some more with some additional cases in this amyloid imaging library. Okay. So clinical case discussion part 2. This same patient, right, that 63-year-old man, unfortunately, after another year, his dementia scores have continued to decline. Went from 26 to 20, 24 to 15, and his patient and his family are interested in therapeutic options. Here is his amyloid PET scan. Right. In order to get an amyloid targeted amyloid antibody, of which is only one full approval right now, lecanemab, you have to have demonstrated positive amyloid biomarker. And you can do that with amyloid PET. Start the cerebellum, good white and gray matter contrast in the cerebellum is expected. Temporal occipital, positive, right? I can't trace out that temporal ridge of white matter. All that activity is going out to the periphery of the brain. Smooth, okay? Precuneus posterior cingulate is filled in here. It's positive. Should have a big diamond clear space there. Frontal region, don't have that diamond clear space. The activity in the midline almost touches. That gray matter in that midline on both sides is filled in, okay? Again, smooth activity going all the way out to the edges in the frontal region as you get into your parietal region, also filled in here. Note, a lot of atrophy in the parietal region near the vertex here, very commonly seen. Do not fall for that being negative, okay? You can pull up those fused images. Don't read off the fused images, but you can pull that up to really prove to yourself that this is just due to deep insulsi, cortical atrophy. Stay away from those regions, okay? Don't call it negative. All right. Next audience polling question. Consider this 63-year-old man now with progressive cognitive impairment based on his clinical presentation and available imaging. What is the most likely diagnosis? Oh yeah, in case you're wondering, and in case anyone really spotted out who's got the eagle eyes, see that little area in encephalomelia there? You can even see that. So, but he is amyloid positive here, so the most likely diagnosis now here is Alzheimer's disease. Patient returns to clinic after 18 months of anti-amyloid therapy. So that's the full course of lecanemab. And this is his case now, all right? This is his follow-up amyloid PET scan, all right? Let you see the overall view of it. And now we're gonna do side-by-side comparison. So before therapy is on the bottom here, look at that frontal region. Remember I said, particularly medially, I think is a nice place to look at. See how it almost touches in the midline, that gray matter on both sides of the interhemispheric fissure. It's filled in, and now look, it's become negative, right? And back here in the precuneus region, right? It's become negative here. Look how it was filled in before. Okay, not completely negative in the temporal occipital region. It's improved, but it's not completely negative there. There's still probably some sparse plaque there. And when you quantify it here, you can see the decrease from prior to therapy to post-therapy, a decline in the whole cerebrocortical region. So the lecanemab actually effectively pulled the well, actually, I don't know if it's specifically lecanemab here, but the anti-amyloid antibody here decreased the amyloid burden in this patient's brain, and hopefully replicated what was seen in the clinical trial phase 3, which was slowed the cognitive decline. So which of the following is the most appropriate conclusion in this patient who's been treated with anti-amyloid antibody therapy? There's a QR code. And the answer is clearance of cortical amyloid. Okay. Again, the scan tells us nothing about his clinical response. That's the neurologist's job. ARIA or amyloid-related imaging abnormalities requires your MRI, T2 to look for RAE for edema, and T2 star or some susceptibility imaging for your RAH for hemorrhage. Okay. And so key takeaways, amyloid and tau PET can be used to diagnose and stage MCI and dementia, pathologic staging now. The advent of FDA-approved disease-modifying therapies for AD has really changed the AD landscape of neuroimaging for AD. Amyloid PET currently plays a key role in identifying those patients who are eligible for amyloid-targeted therapies, making sure that target's there. Just like we do in other areas of nuclear medicine, this is theranostics. Neurotheranostics. We are more in the diagnostic part where we make sure that that specific target is present, that you're going to deliver that specific targeted therapy for. And potentially in the future, amyloid PET may be used to decide when to stop or stop your anti-tau therapy. You can imagine if someone's already become amyloid negative, why do you keep giving them the anti-amyloid antibody? There's no more amyloid to remove in their brain, right? You're only having the side effects and the cost. And tau PET may be used for patient selection in the future, as you can show the much tighter temporal relationship between development of symptoms with tau PET versus amyloid PET. Okay, here's the post-test evaluation QR code. So please make sure to fill that out in order to get your CME credit. And yes. So thank you very much. And I think I'm right at the hour, but I'm available for any questions if anyone has any questions. Thank you very much.
All right, do we have any questions for our speaker? Yes, Dr. Head.
The PET amyloid study, how does that correlate with the genetic markers?
I don't know if you were able to hear that, Dr.
Yeah, if you don't mind repeating the question, just make sure I heard it right.
What is the correlation between the amyloid PET scan and the genetic markers? I know there are these two genes.
Oh, yeah, yeah. Yeah, great question. So, at any cross section in time, if you take, 70-year-olds or 80-year-olds, we've known for a long time that if, for example, the most common one, ApoE, if you are ApoE4 positive, homozygote, you are at least 10, 15 times more likely to develop Alzheimer's disease. And if you take patients of the same age who are ApoE4 homozygote versus negative for ApoE4 wild type, they're much more likely to be amyloid positive. And we actually know this from, pathologic studies before, and even higher burdens of amyloid positivity as well. So, but it's very important, okay? Even these patients or subjects who are ApoE4 positive, or they have some other gene like presenilin, a 1 or 2, that gives them an increased risk, it doesn't necessarily mean that they're going to develop Alzheimer's disease. They're at higher risk, but it's not the sole risk factor, okay? So, in fact, I recently there was a patient in our clinical trial, retired physician, ApoE4, he was 65 years old, Medicare age. I mean, statistically, you're like, he's at way higher risk for being amyloid positive, and his family members develop Alzheimer's at an early age, but he was still amyloid negative. Visually, his quantification, he probably had at least, he was not completely negative, but by visual interpretation, he was still less than 40 centiloids by my visual estimation. So it's a much higher risk, but I think in those patients, it's maybe even more important to make sure, where are they really? Just because you are that high genetic risk doesn't mean you're going to absolutely develop Alzheimer's disease or be amyloid positive. But on the other hand, if you are amyloid positive, you can at least consider being enrolled in a trial that might fit your eligibility. Hopefully was that the question?
Yes, thank you.
Okay.
At the same token, what is the relationship with the tau proteins and the antibodies?
Yeah, how long you are amyloid positive to when you develop tau, we don't exactly know quite yet, but the relationship holds pretty well. Again, that if you are completely preclinical, you have no symptoms whatsoever, no even subjective decline, the odds of being tau negative are quite low. But if you are so unlucky as to be tau positive at that point, the clock is very likely ticking. Especially with fluoroscopy, where it's not the most sensitive test for tau pathology. By that time, when you're tau positive by fluoroscopy, you're already really considered to have levels of tau that are seen with Alzheimer's disease, like, real dementia. So again,
That position that you mentioned, did you do that tau besides the amyloid? Did you do that tau too? Or just the amyloid?
In the physician that you mentioned, Dr.
Yeah, the
Close.
one that had.
oh yeah, actually, yeah, he actually was as part of the trial he was in, we measured tau also. They got both, and he was negative as well. Yeah, so the paradigm of you have to be amyloid positive first, and then you become tau positive is very good. Nothing's perfect in medicine. But if you are truly, without a doubt, amyloid negative and you are tau positive, you really need to question whether you're not questioning that they're tau positive. You need to question whether they actually have Alzheimer's disease. It might be another tauopathy. Some of the other tracers that we use are not so specific for Alzheimer's disease. And so you actually may have another tauopathy, maybe a primary tauopathy, like one of the frontotemporal dementias. And then that information hopefully will really feed back to the neurologist to fine tune their assessment. Like, okay, let's rethink, maybe this isn't Alzheimer's disease, maybe another type of dementia that is amyloid negative and tau positive. Tau is much more complicated than amyloid. Amyloid's amyloid. We image the aggregated form of amyloid, these amyloid neuritic plaques. But tau, there's many isoforms. There's 3R, which is 3 repeat. There's 4 repeat. Alzheimer's disease is actually not a pure one. It's actually 3R and 4R, but there's other types of tauopathies. There's more pure one way or the other. So kind of more complicated. But if someone truly is amyloid negative, and you're considering Alzheimer's disease, technically speaking, there's not much value in testing them for tau because they should be tau negative if you're really, really concerned exclusively about Alzheimer's disease. If they're truly amyloid negative and tau positive, there's a good chance that they're not, Alzheimer's disease. It's another type of dementia, another type of proteinopathy. Might be a primary tauopathy, for example, like I was saying. But again, there's always a chance of misinterpretation of these scans. That atrophy can really throw off your interpretation. It really is, I think, the most common reason for mistakes that I've seen in people who are early in reading. And look, that low dose CT that we get with our PET CTs aren't the best, but you're not trying to pick up subtle subdural hematomas or anything. You use it for correlation for atrophy, and it's quite helpful. Towards the vertex of the brain really gets susceptible to atrophy in a lot of cases. So particularly in the parietal regions, focus more on the inferior regions. If you open up the coronal CT, you'll see that generally, as you go higher up to the vertex of the brain, the atrophy tends to worsen more and more in your front parietal regions in particular, and potentially even more in your frontal regions. But also, in your temporal, that regions as well, just emphasize more your interpretation of amyloid PET, where in your CT, you have less atrophy.
All right, do we have any other questions? Okay, no more audience questions. All right, thank you so much, Dr.
Okay. Oh yeah, absolutely. Thank you very much for your attention and your interest in this exciting area of nuclear medicine. We had a lot of excitement when we got those approvals, all those years ago. So now we have this resurgence. So encouraging everyone, find out which tracer you have access to and do that reader specific training. Thank you very much for your attention. Hope to see you all maybe at the annual meeting.
Thank you.
Thank you.